Okay, so let's do this question. This section is about angiology or blood vessels. I think this will be the second part of blood vessels. A 20-year-old man comes to the physician because of a 3-day history of reduced night vision. His medical history is significant for mild intellectual disability, chronic diarrhea, bilateral retinitis pigmentosa, and muscle weakness. His 15-year-old sister has had similar symptoms. Physical examination shows ataxia, hypotonia, and loss of deep tendon reflexes. Laboratory studies shows erythrocytes with spiny projection and a serum total cholesterol concentration of 60 milligram per deciliter. Deficiency, which of the following apolipoproteins is the most likely cause of this patient's condition? Um, so again, this question is talking about apolipoproteinemia. Okay, A beta lipoproteinemia. A beta lipoproteinemia. So let's go to that. A beta lipoproteinemia. So let me write it down here. A beta lipoproteinemia. Okay, so this is a disease. This is autosomal recessive disease, but let's break it down first before we go to autosomal and so forth. A means without. Okay. Emia is in blood. I'm color coding it for you. And then beta lipoprotein means beta lipoprotein. So A means without or no. So if I were to define this, this means lack of beta lipoprotein in blood, just like anemia. Okay, so this is low quantity, decreased quantity, or lack of, or no presence of beta lipoproteins in blood. Okay, and beside the apolipoproteins are plasma protein that are responsible for carrying lipids such as cholesterol, triglyceride, phospholipid, and so forth. Okay, number one, it is autosomal recessive disease. Okay, and it's deficiency of microsomal triglyceride transporting protein. It's deficient in this disease. This deficiency leads to decrease in the activity and functionality or production of apolipoprotein B48 and apolipoprotein B100. So these two will be deficient. Let me put here negative signs to indicate that they're deficient, or I should put decrease sign to indicate they're decreased in plasma. If you don't have this protein in plasma, that means there are no proteins available to carry lipids throughout plasma or blood. Okay. All right. So that's one. Second thing is, what is the function of each? Well, for that, I'm going to draw here. So just give me a second. I might not be talking and I'll draw for you. Let's say this is the intestine. Okay, let's do intestine first. So intestine, right? So this is intestine. Intestine has enterocytes, and let's do a blood vessel. Okay, and then let's do a liver. So just to draw these structures, I like drawing because it helps me in retaining information. Okay, all right. Okay, so lipids such as triglyceride. Okay, when we eat lipids or fat, the digestive system will break it down. You remember the pancreatic lipases, it will break it down, the oral lipase, pancreatic lipase, and then eventually, so you'll break it down by phospholipase, triglycerides, and esterases, and so forth. And all the lipids are eventually converted to fatty acid, triglyceride, and phospholipids, and cholesterol. Okay, so fatty acid, cholesterol, and what else would it be there? So fatty acid, cholesterol, Yeah, what am I missing? In phospholipid, there you go, phospholipid, so 3. So in the digestive system, eventually the end product of digestion of lipid would be cholesterol. Can't believe I'm going in that detail, but whatever, I started it, so let me finish it. Cholesterol and phospholipid, and then fatty acids. All these are individual, and then these guys combine within the enterocyte cells of the intestine, and they form this a ball of cell called chylomicron. Okay, chylomicron is a combination of these lipids plus proteins, and one of those protein will be apolipoprotein beta 48. Okay, so beta 48 is responsible for, I'm going to write here beta 48. Beta 48 is responsible for absorption of this chylomicron from intestine into blood, and then from blood it's carried all the way to the liver. So beta 48 is responsible for transport of lipids from intestine into liver, but this is all done through blood. Okay, then the next one is beta 100. The function of beta 100 is to transport these lipids into adipocytes for storage, which is fat cells, and myocytes. Myocytes are muscle cells, especially cardiac and skeletal muscle. See, cardiac and skeletal muscle predominantly use fatty acid or lipids for energy, not glucose. In the state of exercise, it uses glucose. At resting state, it primarily uses fatty acids. Okay, so that will be the purpose of these lipids. Good. So now we kind of have an idea what these lipids do. If these lipids are deficient, that means, let me use red. You can't do this transport. As a result, all the lipids will accumulate within intestine. Okay, so they will accumulate within the intestine and it cannot be absorbed. So in plasma, these lipids will decrease. So the quantity of these lipids will decrease in plasma. Okay, so plasma lipids will be decreased, triglycerides, so whatsoever. And also its transport to the liver and also to muscles, skeletal muscle, and cardiac muscle for energy use. Okay, all right, so if that's the case, what is the consequences of that? I will delete all of this. Let me delete. Does this help me? No. This, no. Which one? Maybe let's do this. There you go. So I'm going to delete all of this to have room for me. Now that we have done the basic pathophysio of lipids, we can go to diagnosing this condition. So if there are lipids that cannot be broken down and they cannot be transported from intestine into tissue or liver, so that leads to malabsorption. So the first thing is malabsorption, and signs of malabsorptions are two things. Okay, so malabsorption, this is strictly lipid malabsorption, so we'll be looking for fat soluble vitamin deficiency, fat soluble vitamins, vitamin deficiency. Okay, and those are vitamin A and vitamin K and vitamin D. E, let's leave it alone for now. Okay, so that's that's one thing. In addition to that, so the other sign of malabsorption will be diarrhea, specifically steatorrhea. So we'll be looking for those things. Okay, so fat soluble vitamin deficiency, and then of course lipids deficiency, right? Lipid deficiency. Okay, so the symptoms we would expect. Steatorrhea is diarrhea, which is foul smelling, fatty, pale, floating. Remember those things. Floating. So this diarrhea where stool is floating in toilet water. It's bulky, it's fatty, it's foul smelling, and it's pale. So that's steatorrhea. Always when you see that, you think of fat malabsorptions. Okay, if there's lipid deficiency, remember that this is genetic disease, it's autosomal recessive, it's So that means it will be present since birth. Lipid malabsorption in childhood will lead to devastating consequences because lipids, fat, are responsible for brain development. Remember, myelination is fat, sphingolipids, and so forth. So this can lead to mental retardation. Okay. Plus, if there is some decrease in myelination, it can lead to ataxia. Okay. Failure to thrive, and maybe retinitis pigmentosa, like in this question we're talking about. Muscle weakness, hypotonia. Plus, in addition to that, there might be peripheral neuropathy because neuron requires myelin sheath for speed of impulse conduction. So you don't have lipids, you can't do those things. Remember, lipid storage diseases such as Fabry's disease and so forth, Tay-Sachs and Niemann-Pick's disease, all those diseases are lipid deficiency, and you can see all of them will have neurological symptoms to some degree. Okay, so we discussed those things. Next thing is vitamin A is for night vision. So rhodopsin requires vitamin A, and lack of vitamin A will lead to night vision deficiency or night blindness. Vitamin K is used for carboxylation of clotting factors. Okay, clotting factors. So the glutamic residue of clotting factors requires vitamin K for hydroxylation. If you have vitamin K deficiency, the tendency will be bleeding. Okay, leads to bleeding. So decreased night vision was the other one, and then vitamin D is known for, and its function is calcium absorption and reabsorption, absorption from the intestine, reabsorption from the kidney, and this can lead to hypocalcemia, vitamin D deficiency, hypocalcemia, and its symptoms. Look for those things. Okay. All right. So those are the major things we want to talk about in A beta lipoproteinemia. So let's see what are these symptoms are present in this case or no. Okay, so 20-year-old, whenever you hear young, age, usually indicates genetic disease, right? Physician because of 3-day history of reduced night vision. There you go. Reduced night vision. We talked about it here. That's vitamin A deficiency. His medical history is significant for mild intellectual disability. Intellectual disability, we say lipid is required for brain development, so that's why it can lead to mental retardation. Chronic diarrhea. Chronic diarrhea is the same thing as I talked about. Steatorrhea is specifically for malabsorption of fat. It's a foul-smelling, bulky, pale, floating stool. Okay, bilateral retinal pigmentosa, so night vision again. Blindness, it can lead to not only night vision, eventually to blindness, right? Muscle weakness, in this case, we talked about hypotonia. His 15-year-old sister, similar sense, so it's genetic. Physical examination shows ataxia, that's the neurological, right? We need myelination for that, hypotonia, and loss of deep tendon reflexes. These are all neurological things. Okay, so that covers, we should know how to diagnose A beta lipoproteinemia. If you look at the choices, in addition to, remember, this was malabsorption of fat, generally speaking, so the normal total blood cholesterol concentration is less than 200 milligram per deciliter. And in this person, remember that this is 60. So it's telling you that, this person's having malabsorption issues with fat. Okay, and the choice should be C then. We already know that it's A beta lipoproteinemia is the diagnosis. Just wanted to help you how to diagnose it based on symptoms plus what is the pathophysio of this condition. Let's go to next question. Okay, so the next question is, a 25-year-old man comes to the physician because of a periodic numbness and pain of his left arm during the past 3 months. His blood pressure is 125 over 85 millimeters of mercury. Pulse is 75 per minute in both upper extremities. A CT scan of the neck and chest shows compression of the brachial plexus by an accessory cervical rib. Which of the following labeled structure is at the greatest risk for injury during operative removal of the cervical rib? So they're saying is if you remove the cervical rib, which of the following structure can be damaged, which is A, B, C, D, E. Let's identify these structures first. So A is the scalene muscle. A is the scalene muscle. Okay, so A is the middle scalene muscle, because there's B as well. So I thought it was just the scalene. Now I realize there's two of them are labeled. B is the anterior scalene muscle. Okay, that's memorization. You should know this condition. So this would be thoracic outlet syndrome. Just looking at the picture in the question stem, you should be able to identify it. But let's go with this first. C is the brachial plexus. Okay, so it looks like the brachial plexus that are related. Remember, so let's go with D first, then it'll be easier to explain C. D is the subclavian. Subclavian because it goes under the clavicle. Sub means under, clavian, clavicle, clavian. So subclavian artery. It's red. Think of it as an artery, at least based on color, right? And then you have E, subclavian vein. Okay, subclavian vein. As soon as these two structures, the subclavian vein and artery, crosses clavicle, becomes axillary artery. Okay, remember D will become axillary artery, which brachial plexus are related to, because the different cords are related to that portion of the artery are named anterior, posterior, or superior cords. Okay, before that will be. So now I can talk about C. C is, you can think of it brachial plexus, but look, so C is more looking at the root, spinal nerve root, and then they combine, they'll make the trunks, such as upper trunk, middle trunk, posterior trunk, and so forth. Because this is way above the artery, I will say superior trunk, but just say brachial plexus for simplicity. Okay, brachial plexus. Okay, so now we know our structures. The question is asking, if you were to remove the accessory rib, which of these structures is most likely to be damaged? Okay, that's what it says, injury, right? So which of the following structures is most likely to be injured or damaged? Here you go. All right. Now, one thing we need to understand that, let's say this is the vertebrae, 1, 2, 3, 4, cervical vertebrae. Let's say this is 7, this is T1, so this is C7, C6, C5. Okay, so here we have the sternum, right? Manubrium and the sternum, the xiphoid process. So the first rib starts posterior from T1 and it will come attached to sternum. Okay, so this will be the first rib. I'll put 1. And then let's say there's T2. Second rib will start from here and come here. So these are the ribs. Now the question is, I'm going to do the other rib in blue. Let's do it let's do it in blue. Should we do it in blue? Okay, let's do it in red so we can see. There should be no ribs coming from the cervical vertebrae. If there is one, then it's called accessory or cervical rib or extra rib. Okay, this rib starts from the C7, cervical 7, and it comes and it binds, attaches to, it's not a long rib, it's a short rib. So it's attached usually to the first rib. Okay, so it starts from C7 and it'll come and it's attached to, it binds to the rib number 1. So it doesn't come all the way here. So, and this is why the cervical rib will end up somewhere right here. Okay, on that picture. So it's not a full rib, it's half a rib or partial rib, small rib. Just like when we talk about rib number 11 and 12, they're not attached to the thoracic cage, and they're more like behind the kidneys, right? So, okay, so therefore it's not going to affect a lot of structures. Structures that are closely will be affected, such as the subclavian artery and the brachial plexus, but it doesn't affect subclavian vein because the vein is further away from it. If you also pay attention in this picture, the original picture, so let me erase this one, that way we don't get confused. So let's look at this picture, the picture that we already have. You see between A and B, scalene muscle, anterior and middle scalene muscles. Between them is the subclavian vein and the brachial plexus, whereas the vein, subclavian vein, is medial to the anterior scalene muscle. So this structure can sometimes be compressed by these two muscles, the vein, the artery and the nerve. In this case, it's compressed by accessory muscles. So that's why the person will having these neurological symptoms. What are the neurological symptoms? Let's highlight them. So this person's feeling numbness and pain in the left arm. Okay, and that is because of compression of the brachial plexus. Sometimes, if the vessel is compressed, it can also lead to hypoxia of the. In this case, it's the left arm, right? Is it left arm? Okay, so yeah, left arm. So it can also lead to tingling and numbness. But the question is asking which of these structures most likely compressed. Now, this is not good because C and D both are correct. So both C and D can be compressed. Okay? C and D, both of them are compressed, and both of them can be injured during a surgery. Now, I don't think you'll see a question like that on step one. If it is, and these are step one questions directly from them. The issue here is if a question like that comes, what would I choose? I'll choose D, but it's hard because both of them can be injured. I think the main issue here is because it looks like it's the superior trunk of the brachial plexus, which goes way above the accessory rib, whereas the artery is related to the rib, so most likely the rib if you have to remove the thing. But both of them are most likely. Okay. If I were to choose, I'll choose D. So I'll choose D. Let's choose. The answer is D. But just remember that C is also correct. Not the best choice, but it's correct, especially if it's the superior trunk. So if I were to draw superior, how am I going to do this? Here is the artery, and then on top of that would be the superior trunk, the inferior trunk, the middle trunk, and then the superior trunk. So the superior trunk, in this case, like you see it in this picture, is way above. But when this under the clavicle, they go behind in superior and middle. Okay, so I will choose D. Let's hope this makes sense to you. Let's do the next question. So this is mostly anatomy question. You should know your anatomy really well. Okay, so the next question is, let me get my highlighter. Next question is a 28-year-old American who is visiting Afghanistan, climbs one of the tallest mountain to the altitude where the ambient partial pressure of oxygen decreases from 160 at the bottom of the mountain to 60 millimeters of mercury at the top of the mountain. The decrease in ambient partial pressure of oxygen will most likely cause an increase in which of the following in this patient? Okay. So this is more a physiology question. They simply want to know if you go from a high partial pressure of oxygen to low partial pressure of oxygen, what physiological changes would occur. Okay, let's say you go from the bottom of the mountain to the top of the mountain. At the bottom of the mountain, there's much more oxygen available. At the top, there's much less oxygen available. This is why pilots that drive like these big fighter jets, remember, they're wearing a mask on their mouth. This is why we have oxygen masks on airplanes when we, just in case something happens at the higher altitude. Because of the higher altitude, there's less quantity of oxygen available, and that can lead to hypoxia. All right. So now, choice A, aortic diastolic pressure, subclavian pulse pressure, aortic systolic pressure, renal artery pressure, pulmonary artery pressure. Okay, pressure. Let's see how pressures work. If you have low oxygen, so the partial pressure of oxygen is low, what would that lead to? So the body senses like, oh my God, there's low pressure of oxygen. I'm going under hypoxia. I'm getting suffocated. Let me increase. The body is going to respond how to increase the delivery of oxygen to the tissue to avoid hypoxia. So how does it do that? Number one, it can do by vasodilation. So when you vasodilate, that means more red blood cells are able to travel from lungs okay, into your tissue to deliver oxygen. So that's one way. Think of it this way. How could I increase delivery of pizza to my home? Well, let's say somebody's getting married and I want to deliver like thousands of pizza on time. So one way is to make sure there's no traffic. So that wouldn't delay the delivery of pizza. Number two, I will make sure that there's more drivers, more cars to deliver more pizza. Okay, so there's two ways. One is by roads. In this case, that's the vessels. Okay, so vasodilation will allow for more blood to circulate and deliver oxygen to the tissue. So that's one way of increasing it. Whatever oxygen we're getting, let's deliver to tissue faster and more of it. Okay. Number two is by increasing red blood cells, RBCs. If you have more RBCs, they can carry more oxygen, and these RBC can be delivered faster by blood vessel to the tissue. Okay. And if RBCs increase, that means I want to also increase hemoglobins within the red blood cells so that can bind more oxygen. So these are some of the ways that can deliver more oxygen to your tissue in the case of need and emergency cases. If somebody travels to high altitude at a faster rate, like small capillaries in the retina can start growing. So the retina requires more oxygen, let's say, and it can start doing something called neo angiogenesis or angio. Okay, not angiogenesis, which is production of new blood vessels or capillaries. Sometimes that can lead to blindness. That's what they say. So you have to. Okay. Now, so we know this. If you have vasodilation, so that means vasodilation. Remember, when blood vessels dilate, that leads to decrease in TPR or total peripheral or just a peripheral vascular resistance. Used to be called TPR, right? So, and that leads to decrease in blood pressure. Okay, this leads to decrease in blood pressure. So that would be this is true of the entire body except lungs. So let's see, aortic diastolic pressure. We are looking for something. The question is asking for increase. The question is asking which of the following will increase. Okay, out of the choices, which will increase. So aortic diastolic pressure, look right here. We're saying its pressure will decrease, right? We're saying pressure will decrease. So that's incorrect. Subclavian pulse pressure. Pulse pressure is the difference between systolic and diastolic pressure. Okay, pulse pressure will decrease if your diastolic pressure increases and your systolic decreases as well. Okay, so pulse pressure. Let me just do this. Pulse pressure is the difference. I'll write it here. PP. Pulse pressure is the difference between systolic blood pressure and diastolic blood pressure. So the only way you can have a small amount, this can decrease if systolic pressure decreases and diastolic pressure increases. So let's say this is 100 and diastolic pressure is, let's say, 85. The pulse pressure will be what? 15. But the normal thing we usually think of normal blood pressure is 120 systolic and diastolic is 80. The difference is what, 40? Yeah. So remember, it decreased from 40 to 15. So that's pulse pressure. Now, vasodilation, usually it's when vessels dilate, all of them dilate. But the only way we can have this difference if the heart is contracting slower and weaker, and then blood vessels are dilating, then constricting, then this can happen. So this is not the right answer, and it wouldn't make sense. Okay, aortic systolic pressure, no. We already talked about systolic diastolic pressure are decreased when it comes to hypoxia. Okay. Systolic should increase because the heart will start contracting, to some degree, but not much. Okay, renal arterial pressure is the same. So the best way to do this is let's divide the blood pressure. We have systemic blood pressure, versus pulmonary blood pressure. Okay. So pulmonary blood pressure is a little bit different because it's regulated by the right ventricle and resistance of blood flow through lungs. Now in lungs, In lungs, when you have hypoxia, so hypoxia, this low pressure of oxygen, let's say hypoxia will cause systemic blood pressure to decrease, so it can deliver more, okay, because of the decreased peripheral vascular resistance. But hypoxia causes increase in lung resistance and lung vascular resistance. So I'll say pulmonary vascular resistance. So vascular resistance increases. Why is that? The whole idea of that is, remember the VQ mismatch, blood flow and perfusion and ventilation ratios. Okay. Let me erase this so that we can see what I'm talking about. Not this, yeah. Okay, so in lungs, let's say this is lung. Okay, so we have the different zones, physiological zone, zone 1, zone 2, zone 3. In zone 3, there's a lot more blood flow. Q stands for blood flow. Blood flow is much, much higher. In zone 2, blood flow is okay. In zone 1, blood flow is the least. That's because of gravity. Okay, gravity is going to cause blood more to come to the lower lobes of the lungs compared to upper lobes. But air, so this was blood flow, ventilation, which is oxygen, right? Ventilation is highest in the upper lobes and lowest in the lower lobe. So that's ventilation. Okay. Now, if there is decreased blood flow to lungs, okay, so if there's less oxygen will be the highest in which zones? In the upper zones. So you want most of the blood to go to this area, to the upper zone, in the case of hypoxia or high altitude. This is why in lungs, hypoxia or lack of oxygen will cause vasoconstriction, because it shunts blood to this area. So where will be the least oxygen? In here. The least oxygen is in right here in the lower lobe. So that will cause hypoxia. This is relatively hypoxia of lung tissue, and this leads to vasoconstriction in this area. Okay. So if there's vasoconstriction in the lung and the pulmonary arteries, that means blood pressure will increase because there's resistance to blood flow. Remember we did a previous question, blood pressure depends on cardiac output times vascular resistance, right? Vascular resistance output R. Okay, so the best choice in this case would be pulmonary artery pressure will increase. Okay, so this you should memorize it too. Remember that everywhere in the body hypoxia causes vasodilation, and except in the lungs. In the lungs, hypoxia causes vasoconstriction. So maybe that will be helpful. So let me write it down. Sometimes some students love memorizing. So for them, maybe this will be helpful. For others, they like to understand the concept. So general rule. What happened? Okay. So general rule is this: hypoxia. Hypoxia causes vasoconstriction in lungs. Okay, we already discussed that, the reason why. But hypoxia everywhere else causes vasodilation. Vasodilation. The rest of the body. So hypoxia in the rest of the body causes vasodilation. Only in lungs it causes vasoconstriction. Why the rest of the body? Because if you have vasodilation, then it means you can wash out carbon dioxide faster. So you can remove carbon dioxide faster in the waste products that are produced by lack of hypoxia, by lack of oxygen. So if you have no oxygen reaching the tissue, guess what mechanism would your tissue use to generate ATP? Glycolysis. And the end product of glycolysis is what? Carbon dioxide, waste products such as lactate. And you want to wash out lactate. You want to get rid of it faster. You want to remove it from tissue, and you want to bring oxygen. You want to bring oxygen to the tissue faster. So to do all these things, you must have vasodilation at the tissue level in the rest of the body. But in lungs, your main goal is not using oxygen. The main purpose of lung is to deliver oxygen to blood, right? So it can be delivered to the rest of the tissue. It's oxygenation of RBCs. So the main issue of lung is oxygenation of blood. Okay. For this purpose, you want to shunt blood to those areas where you have the most oxygen. So wouldn't you choose to shunt blood or direct blood to those areas of the lung that has the most oxygen so you can carry it? The area that don't have oxygen, why would you want to even send blood to that area? So this is called shunting or selective shunting of blood. Okay, hopefully this will make sense. Let's go to the next question. Okay, so this is the next question. A 65-year-old man comes to the physician because of substernal chest pain that radiates to the left jaw and shoulder. The pain, so there's something missing, that should be the pain. The pain comes with heavy activity and subsides with rest in nitrate. Angiography shows a stable plaque in the anterior descending coronary artery that is blocking 60% of the arterial lumen. During a 2-mile jog, adenosine released by myocardial cells would most likely act on which of the following coronary artery wall component? Okay, so there's two things. These questions could be confusing, but at the end, even though it's a clinical scenario, but they're asking about the basic sciences information. So number one, stable angina. Stable angina is caused by, let's say this is a coronary artery. In the coronary artery, there's a stable plaque. Okay, stable plaque. Stable plaque is a plaque that does not rupture. That's what, before it ruptures. Once it ruptures, it's no longer stable. So there's a plaque, a cholesterol plaque, or atheroma. Okay, so when you have this atheroma, this causes decreased blood flow. So the blood flow through here is now decreased, right? Because this leads to stenosis, narrowing of this coronary artery. At rest, guess what? The amount of blood passing through this coronary artery, in this case it was left anterior descending coronary artery. At rest, the amount of blood passing through this artery is enough to supply the myocardium, okay, especially the left ventricle, right? Because left anterior descending. So it's enough to supply oxygen and nutrient to your myocardium. But when you do activity, when you exercise, the demand for oxygen and nutrients increases. And this, because of this, this artery is narrow, it doesn't allow enough blood to pass through. So this will cause pain. So that's why you will have, with stable angina, you will have exertional chest pain. I think of it this way. Stable, think of it stable. S, stable is S, stable angina. So let's think of it as sports chest pain. So chest pain that's induced by sports or activity or anything like that, okay? So that's one. Now, the pain is always substernal. You know that, I don't have to say that. It's substernal. It's radiates to the left jaw and shoulder. So that's typical of angina. And the pain is non-positional. Why do we have to mention that? Because pain produced by GERD is positional. Pain produced by pericarditis is positional. Chest pain produced by angina is non-positional, but chest pain produced by pneumonia, by pneumothorax, so pneumonia, lung problems, maybe pericarditis or hemothorax, those are usually positional, okay? Okay, so this chest pain is non-positional and it's substernal. You should memorize these things or understand them, why it makes sense, and usually radiates to the left jaw or shoulder. because that's the left phrenic nerve, right? Okay, so we diagnosed this was stable angina, and an EKG for stable angina, ST, will be depressed. So think of ST under the table, stable, ST under the table, stable, ST under the table. Whereas for other angina MI, it's elevated. Okay, so far we discussed, I want to make sure I cover these parts. Let's see. We discussed the substernal chest pain. we say it's reading to the left jaw and shoulder, and it's activity induced. And oh yeah, it subsides with nitrate. Okay, with rest and nitrate. Why does a chest pain produced by stable angina decreases with rest? Because at rest the demand of oxygen decreases, so there's no chest pain, there's no hypoxia. Also, nitrate will cause vasodilation, so it will improve blood flow to the left myocardium, so it will improve the chest pain. Angiography shows stable plaque, we already discussed that. Anterior descending coronary artery blocking 60% during the 2-mile jog. Adenosine, oh there you go, adenosine. Adenosine released by myocardial cells would most likely act on which of the following coronary artery wall. So now that's the second part. The second part is, what does adenosine do? Adenosine is, so if you take ATP, when ATP is used, you will get AMP, and eventually you can just get adenosine, right? Adenosine is the byproduct of metabolism. It's a byproduct of metabolism. What it increases, it tells you that in this case, myocardium is going through metabolism. Okay, so this will usually cause vasodilation. And coronary artery is not so much regulated by hormones or by neurotransmitter. It's called the local regulation. It's regulated by itself. So when adenosine locally increases, not in the entire body, so the adenosine that increases locally in the myocardium, it can cause vasodilation locally. So vasodilation. Okay. So this is local blood flow regulation. So local regulation of blood flow. Who does that? Adenosine. Extremely important. Okay. Now, to understand this, we need to go to, let me draw an artery. Okay. Let me draw an artery. Okay, so most arteries have 3 layers. The outermost layer is known as adventitia. Yeah, which is A. So I'm going to label it A. And then antemma is the innermost layer, which is blue. And that's B in our picture. And then red is the middle layer is media, which is C. Okay. Internal elastic membrane is between A and C. Between A and C, there's a membrane, and this is called internal elastic membrane, which is D in our picture. E is between, oh sorry, that's between media. So let's say this is E, and the one between blue and red, that is D. Okay. And then basal lamina is also close to D and F together in that sense. And endothelium is basically the innermost right here. That will be the endothelium. Okay. So our blood vessels have 3 major layers: tunica adventitia, which is A, and then tunica going from out in. The outermost layer is adventitia, the innermost layer is antemma, and the middle layer is media. Antemma is actually made of endothelium. Okay, so endothelium, which is G. Okay, G. So it's made of endothelium. G. It's also made of basal lamina. It has basal lamina, which is the basement membrane. It's component of that. So in this case, it's F. And it also has internal elastic, which is C. So tunica intima, its components are B, F, E, and D. There you go. Okay. All right. The purpose of adventitious stabilization of blood vessels. Intima is endothelium, mostly secretion and preventing clotting, blood flow, and things like that. Media is vasodilation and vasoconstriction. Vasodilation and vasoconstriction, right? So that's primarily vasoconstriction. That's primarily the function of media. Um, so, because this question is asking about adenosine. Adenosine released by myocardial cell will most likely act on which of the following coronary artery component. So, the purpose of adenosine is vasodilation. The only layer that's responsible for vasodilation is tunica media. Okay. Hopefully, this was helpful. Let's go to next question. Okay, so the next question is a 30-year-old. My highlighter, let me get my highlighter because it usually helps me. A 30-year-old woman comes to the emergency room because of a sudden onset substernal chest pain. EKG shows ST elevation in leads 1 through 4. Remember the previous question you said ST depression stable, right? Coronary angiography shows no plaque. Patient is started on calcium channel blockers. Which of the follow which leads okay, so he's starting calcium channel blocker, which leads to increase in vascular diameter by 2 folds. What is the effect of this therapy on coronary blood flow in this patient? Okay, first let's see what this person's having. So it's a female, okay, brought to emergency room because of substernal chest pain, most likely angina, but then EKG shows ST elevation. ST elevation. Okay, coronary angiography shows no plaque. No plaque. Okay, so this scenario, chest pain, I'm going to spend a little bit of time on this. So whenever you have chest pain can be due to MI, can be to angina, and angina can be stable, unstable, or uh, uh, variant angina. So chest pain, and then you have ST elevation. Okay, and angiography shows no plaque. Usually, when I have just this thing, chest pain and ST elevation, let's just talk about this first. When I have this scenario, what do I think of? I think of unstable angina, or MI. So let's just say coronary, acute coronary syndrome. Acute coronary syndrome. Okay. Now the difference is between these two. In angina, troponin is normal. Output decrease. But in coronary artery syndrome, or let's say MI, let me just say MI, because unstable angina is also part of coronary acute coronary syndrome. So let's say myocardial infarction. Myocardial infarction, or MI. Okay. In this case, troponin is elevated, so that's what will help me. Anytime you have a patient with chest pain, your first suspicion should be the worst case scenario. If it's not, that's great. You don't have to do much. But if you miss it, you can have somebody die without being careful enough. So as a clinician, your job is whenever somebody has chest pain, think of the worst case scenario, in this case, myocardial infarction. So the next thing you do is EKG. On EKG, you see ST elevation. If it's ST elevation, it's unlikely to be stable angina, because stable angina is related to exercise activity and ST depression. Remember we said ST under the table, stable? Okay, so ST elevation, chest pain, I'm going to think of unstable angina and myocardial infarction. This question doesn't talk about troponin, but if you were to differentiate between unstable angina and myocardial infarction, the next thing is what? Look at troponin. If troponin is elevated, it's myocardial infarction. If troponin is normal or decreased, You shouldn't say decrease normal, then it's unstable angina. Good? All right. So since we do that, but here we're saying is angiography, angiogram. Angiogram is negative. It shows you what? It shows you no plaque. And that is 100% diagnostic of variant angina. Variant angina is where there's no plaque, it's vasospasm. So variant angina is one of the three types of angina. In this case, the main issue is vasospasm. The main complication, the underlying cause or the pathology is what? Vasospasm. So there's no plaque. And usually these patients are smokers because smoke damages endothelium, and endothelium can release factor like nitric oxide, thromboxane A2, and prostaglandin I2, and blah blah blah, and that can make the the media, the tunica media, or the muscular, the smooth muscle of blood vessels, resistant to those things or tolerant of. So become super sensitive or tolerant. In most cases, it becomes super sensitive, and that can lead to vasospasm. Okay, so smoke. So look for those things: vasospasm, and of course, females. This is common in females. So when you have this thing, you should think of variant angina. So this diagnosis in this patient is variant angina. That's our first thing. Now that we have defined this to be variant angina, the drug of choice for variant angina is calcium channel blockers, okay, like verapamil or dalteism. So calcium channel blocker, then the question is asking calcium channel blocker will increase vascular diameter by twofold. So if this is a blood vessel, the diameter of this blood vessel is increased by two folds. Because of who? Because of calcium channel blocker. If if the artery was this much before narrow, and then with calcium channel blockers, you increase its diameter, okay, that means more blood flow through here. So blood flow should increase. But if you cause diameter of blood vessel to increase by twofold, how much would you increase blood flow by? Okay, to answer these questions, let's go here. Number one, blood flow. Q is a symbol for blood flow. Blood flow equals to change in pressure. Okay, so it depends on pressure and resistance. So this equation you should memorize. I'm going to delete these other things so you don't get confused, because we already talked about it. Okay. So now the next step is, how do we answer this question? Our question is, the question is talking about vascular diameter was increased by twofold. So this effect will increase blood flow by how much? Okay. What happens to coronary blood flow when you increase the diameter by twofold? That's all. Very simple thing. If we increase diameter by twofold, what will happen to blood flow? So the formula for blood flow is based on blood pressure. As you increase blood pressure, blood flow will increase. That makes sense because you can push much harder to these vessels. But if you increase resistance, blood flow will decrease. So blood flow is inversely related to resistance, directly related to blood pressure. Okay. All right. So again, in this case, we still don't have anything. This formula doesn't give us anything about diameter because we want to know diameter. So there's another formula. Okay. Another formula is that in another formula is that resistance, in short, approximately, resistance is directly related to, how should I say, to radius. Okay, so resistance is inversely related to radius to the fourth. Okay, the big R is resistance to blood flow. Okay, small r is radius. Q is blood flow. So just in case you want to know these. Okay. Radius, diameter is twice the size of radius. Okay, so radius will be 1/2. So that's the thing. If you increase diameter by 2 folds, that means you increase radius by 2 fold as well. Okay, if we combine these two formulas, so we have blood flow Q equals to change in pressure over radius. Okay, change in pressure divided by radius. Divided by resistance, sorry. And capital R equals to right here. So let's substitute this formula. So let's substitute this part for R.